Welcome to the lab. Heart disease kills more women every year than all cancers combined. And the reason so many of those deaths are preventable is not that women lack access to treatment. It is that heart attacks in women over 60 often do not look like heart attacks, not to the woman experiencing them, and in too many cases, not to the first doctor she sees. Today we are going through 7 warning signs of a heart attack that research has specifically identified as most commonly missed in women over 60. And stay with us until the very end, because the 7th symptom is the one most doctors never warn patients about, and it may be the most important of all. Before we go through the 7 signs, I want to ask you something, and I genuinely want to hear your answer. Have you, or a woman you love, ever experienced something unexplained? A deep fatigue that felt different from normal? An episode of nausea with no obvious cause? An aching jaw or neck that came and went without explanation? And was it dismissed? By a doctor, by a family member, or even by yourself, as stress, hormones, or simply getting older? Write it in the comments right now. One sentence. Because the pattern of misdiagnosis in women is not rare, it is documented, and it often begins with an experience that was real but was not taken seriously. Your observation might give someone watching today the courage to act. Here is the biological explanation. And it matters. A landmark analysis of over 1 million heart attack cases published in the New England Journal of Medicine found that women were significantly more likely than men to present to hospital without chest pain as a primary symptom. This was most pronounced in women over 60, and women who arrived without classic chest pain were substantially less likely to receive timely treatment and had significantly higher in-hospital mortality rates. 2 physiological factors explain this. First, women have a higher incidence of microvascular coronary disease of the smaller branches of the coronary system rather than the large arteries. This produces diffuse atypical symptoms rather than focal crushing chest pain. Second, after menopause, the withdrawal of estrogen removes a layer of cardiovascular protection. Risk rises, but the symptom pattern remains distinct from the male pattern. The result? The symptoms are real. The disease is real, but the presentation is different, and knowing those differences can determine whether a woman receives care within the critical treatment window. Symptom 1. Unusual, disproportionate fatigue. Not the tiredness of a long day or a night of poor sleep. A deep, sudden, or persistent exhaustion that feels qualitatively different. Heavier, more physical, harder to explain. Research published in the journal Circulation found that this was the single most commonly reported symptom in women in the weeks and days before a heart attack. More frequently reported than chest pain, this fatigue is commonly dismissed as anemia, thyroid problems, depression, or simply aging. If the fatigue is new, if it is unlike your normal tiredness, and if it persists without an obvious cause, particularly if it is accompanied by any other symptom on this list, it warrants medical evaluation, not reassurance. Symptom 2. Shortness of breath without physical exertion. Feeling unable to take a full breath while sitting still, lying down, or during very light activity, without any obvious respiratory cause. This happens when the heart is struggling to pump effectively, causing fluid to begin backing up into the lungs. This is commonly attributed to anxiety, acid reflux, or deconditioning. If it is new, if it is worse when lying flat, or if it appears alongside any of the other symptoms in this video, treat it as a cardiac warning sign until a doctor has ruled that out. Symptom 3. Nausea, indigestion, or upper abdominal pressure. The nerve supply to the heart and the nerve supply to the stomach and upper digestive tract share pathways through the vagus nerve. When cardiac tissue is under ischemic stress, it can produce symptoms indistinguishable from severe indigestion. Women experiencing a heart attack are significantly more likely than men to present with nausea as a primary symptom, specifically documented in postmenopausal women by the American Heart Association. If you experience what feels like severe indigestion that is not responding to antacids, especially combined with unusual fatigue or breathlessness, do not wait for it to pass. Symptom 4. Jaw, neck, shoulder, or upper back pain. In women, referred pain from cardiac ischemia more commonly travels upward to the jaw, throat, neck, shoulders, or upper back, rather than following the classic male pattern of shooting down the left arm. This pain is typically aching, pressure, or tightness rather than sharp pain, and may come and go over hours or days. If unexplained jaw or neck discomfort appears alongside unusual fatigue or breathlessness, even without chest pain, it should be evaluated as a potential cardiac symptom. Symptom 5. Cold sweats or clamminess without exertion or fever. When the heart is struggling to maintain adequate output, the body activates the stress response, producing cold, clammy perspiration. In older women, this is almost universally attributed to a hot flush. The critical distinction is that cardiac cold sweats are cold, not warm. They are accompanied by a sense of feeling unwell rather than a wave of heat. Cold perspiration in the upper body without obvious physical cause, particularly combined with any other symptom on this list, is a recognized indicator of reduced cardiac output. Symptom 6. Sudden dizziness or a feeling of near fainting, unrelated to standing up quickly. When cardiac output is compromised, the brain may not receive adequate blood supply, producing sudden dizziness or a feeling of being close to losing consciousness. Cardiac-related dizziness comes on at rest or during minimal activity, may be accompanied by nausea, and does not resolve quickly the way postural dizziness does. If this occurs alongside any other symptom on this list, the urgency increases significantly. And here's the 7th symptom, the one I promised you at the beginning, the one most doctors never mention, a profound sudden sense of impending doom. Not anxiety in the ordinary sense, not worry about tomorrow. A strong, physical, inexplicable feeling that something is seriously and imminently wrong, often described by survivors as unlike anything they had felt before. The physiological explanation is real. The autonomic nervous system detects the disruption to cardiac function, the falling oxygen, the pressure changes, the electrical instability, before the conscious brain has enough localized symptoms to identify a pattern. The body knows first. The brain interprets it as dread. This symptom is consistently reported by women who have survived heart attacks and consistently dismissed in the moment as nervousness or an overreaction. It is neither. It is a somatic warning signal. If you or someone near you experiences a sudden, overwhelming sense that something is medically wrong with no obvious emotional trigger, that sensation deserves an emergency response, not reassurance. 4 actions. These come directly from American Heart Association and European Society of Cardiology guidelines. Action 1. Do not wait for chest pain. If you experience 2 or more of the 7 symptoms simultaneously, treat it as a potential cardiac emergency, regardless of whether you have chest pain. The absence of chest pain does not rule out a heart attack in women over 60. Action 2. Call emergency services immediately. Do not drive yourself. 911 in the United States, 999 in the United Kingdom, 112 across Europe. Paramedics can begin assessment and treatment before you arrive at hospital. Action 3. If you are not allergic and have not been told to avoid aspirin, chew, do not swallow 325 milligrams of regular aspirin. Chewing delivers it to the bloodstream faster. Do not take aspirin if you have a known allergy, active bleeding, or have been specifically told not to by your cardiologist. Action 4. Know your cardiac risk profile before an emergency. Ask your doctor for your hs-CRP, your fasting insulin, your blood pressure pattern, and your lipid panel including ApoB. Knowing your risk status means you and your doctor can put monitoring in place before symptoms arrive. I have summarized everything on screen right now. Take a screenshot or download the free guide from the description below so you have this exactly when you need it. Keep it on your phone. Keep it somewhere a family member can find it. The reason this matters is simple. In the moment when symptoms are happening, fear narrows thinking. Having a clear printed list removes the question of whether something is worth calling about. It replaces "I do not want to make a fuss" with a specific clinical checklist that gives you permission to act. That list on your phone or printed and kept by your bed is not just a reference. For someone in this situation, it is the thing that means the difference between waiting and calling is almost always the right decision. Knowing what to look for is only the first step. The next step is knowing your actual cardiac risk, which markers to have your doctor check, and what the results mean specifically for someone your age. And to keep this progress going, click the video on your screen right now. It covers exactly that. The blood test your annual panel is not checking, but should be. It is the perfect next step for your heart health. Subscribe to the lab, stay strong, stay safe,